Well, welcome everyone. My name's Dan Lowenstein, and I have the pleasure of serving as your Executive Vice Chancellor and Provost. And as you know, the goal here is to present the recommendations of the Tiger team that I asked Hal Collard to lead on the clinical research space at Parnassus, an incredibly important focus as we think about the Comprehensive Parnassus Heights Plan. So this event has been organized through the Office of Research in collaboration with the Senate. And as you can see, a recording will be available. So if you want to share this with other folks, please feel free to do so. And with that, I'm going to turn things over to Hal Collard, who serves as our Associate Vice Chancellor of Clinical Research. Hal.
Thank you, Dan. Hi, everybody. Thanks very much for joining this town hall. Before I introduce my co-moderator, Sri, I want to take a moment to thank the members of the Tiger team shown here. These members agreed to participate literally on 2 weeks' notice and committed many hours over the last month to developing the recommendations that they'll present to you today. So I'm very grateful to each of them for their willingness to serve on the Tiger team. Okay, so I'm going to turn the presentation over to Sri Nagarajan, who's the chair of the Academic Senate Committee on Space. Sri's going to go over the agenda for today. Thanks, Sri.
Hello, everyone. Welcome. And my name is Sri Nagarajan. I'm the chair of the Academic Senate Committee on Space, and someone who's been involved with various activities around space at UCSF. Delighted to be here co-moderating this town hall with Hal and the other members of the Tiger team. And so thank you for this opportunity. So after our introductions, we will go into the PRAB building and the discovery themes that have been advocated by the Parnassus Research Task Force. Laura Wagner will talk about that, followed by Susan Chang and Carol McGuire will talk a little bit about the high-intensity participant-based clinical research. Dr. Tom Shi will talk about non-participant-based clinical research. And after these three presentations, I will moderate a Q&A session around the issues of clinical research space at Parnassus. So without much ado, I want to thank the members of the task force and the Tiger team for all of their work. Look forward to hearing their initial recommendations and to moderating questions that you guys may have. So back to you, Hal. Thank you.
Okay, thanks, Sri. And for those of you listening, if you have questions during the presentation, please use the Q&A function in the webinar, and we will be sure to get to those questions. All right, I'm going to provide a brief background, and then I'm going to turn things over to a couple of our speakers from the Tiger team. Just to give some context here. So the Tiger team effort was, as Dan mentioned, sanctioned by the Campus Space Committee as part of our ongoing commitment to the Comprehensive Parnassus Heights Plan. And this picture is from the report published in 2019, which shows the high-level vision for our 21st century campus. Hopefully you've all seen this. This is really exciting, and accompanying this physical revisioning has been an equally ambitious effort to redefine our research mission and how we conduct it here on campus. This has really had many components, but there are three task forces to just highlight over the last, 4 years now. First was the Research Space Working Group, which was chaired by John Fahey and Tamara Alliston. Then there was a Parnassus Research Space Programming Task Force, which Lindsay Criswell chaired. And then most recently, the Parnassus Research Programming Task Force, slightly different name, chaired by Tamara Alliston. And this is the genesis of the Tiger team, or the recommendations that came from this final task force. But this has all built upon the work of these previous groups. There were three main recommendations from the most recent task force. The first was to organize Parnassus research programmatically with what they called an integrated continuum of investigators and resources for clinical and laboratory-based research throughout 4 discovery themes. And we don't have time to go into the discovery themes in detail today, but for those of you who haven't heard about them or have more questions or interest in them, please go to space.ucsf.edu, where there are recorded presentations from the task force that go over this in detail. So that was recommendation number 1. Recommendation number 2 was to commit to maximizing the usable life of our existing research buildings. So in other words, committing to remodeling and revisioning of existing space and putting resources towards that. And the third recommendation was to address the urgent need for purpose-built clinical research space at Parnassus. And this is what has directly led to this Tiger Team effort. So this is the background recommendation then for the Tiger Team work. This came again from the last task force mentioned on the previous slide. And it had 2 components. First was a general recommendation to develop 75,000 assignable square feet of purpose-built clinical research space at the Parnassus campus. And this number came from earlier work by the Research Space Working Group, and is what was estimated to meet the current and future needs of the campus clinical research community. The task force then further recommended that the space be organized across the entire Parnassus campus, consistent with the discovery theme framework, and with consideration for an east to west campus clinical gradient, which is part of the Comprehensive Parnassus Heights Plan and is shown in the image here from east to west. As part of the 75,000 square feet, the task force also recommended that 20,000 of it be included in the new Parnassus Research and Academic Building, or PRAB, and that this should consist of a shared clinical research unit for low intensity participant-based research and program-specific space for researchers who are aligned programmatically with the discovery theme, which is discovery theme C, which incorporates the PRAB. So these recommendations were endorsed by the Space Committee, but more detail and discussion of the specifics of the recommendations were requested. And so that leads us to today. The charge of the Tiger Team was to provide the Space Committee with an expanded vision for how to achieve the task force clinical research recommendations. So to do this work, the Tiger Team divided into working groups focused on different aspects of the recommendation, and they're listed there in the bullets. And so the following 3 presentations will address each of those. Okay, so with that background, it's my pleasure then to hand this talk over, not to Laura Wagner, who had to step out at the last minute, but to Pam Ling, another member of the working group. So I'm particularly grateful to you, Pam, for stepping in to present the first working group report. So I'll hand it over to you.
Great. Thanks, Hal. I see you and I are in the same part of Mount Sutro. All right, can you see that?
Looks great.
Okay, so thanks very much. Hello, I'm presenting today on behalf of the this working group members, and the 4 of us met over the course of March to address the vision for clinical research space in the PRAB, and also for additional recommendations for the Campus Space Committee. The specific charge for this working group was to provide recommendations for the PRAB low intensity clinical research unit, and then also recommend accommodating the program specific clinical research space that are aligned with discovery theme C, which is infection and inflammation. So one of the core recommendations of the task force was for this 10,000 square foot clinical research unit in the PRAB, and this is focused on low intensity participant based activities like interviews, questionnaires, group activities, simple biospecimen collection. And this would provide a much needed shared resource for the Parnassus clinical research community in a non-clinical participant-centered setting. The Tiger team reviewed the task force plan and rationale and endorses this vision, specifically that the unit should be a UCSF shared resource, and that space in this unit shouldn't be assigned to specific research groups. The unit should be used for participant-paced research visits that are minimal complexity and which would complement then the higher intensity units on the east side of campus. We endorsed the unit should be centrally managed, such as by CTSI, and easily available to research teams on a scheduled basis. The figure on the right here comes from some recent work by the UCSF Real Estate and the PRAB planning team to identify the key components and design of such a unit. And the Tiger team endorses this work and encourages continued broad engagement of stakeholders to ensure the unit maximizes its value as part of the larger shared research infrastructure across the Parnassus campus. The Tiger team also discussed the clinical research unit design and function in more detail to provide some more guidance to the Space Committee and to UCSF Real Estate. Essential to the success of the unit is really participant-centeredness, which is inviting to the community member, convenient to Parnassus Avenue, and respectful of privacy. These recommendations are consistent with the themes of convivial, comfortable, and contextual in the Comprehensive Parnassus Heights Plan. Really consistent with low intensity research focus. This unit should really be conducting things like eligibility screening, informed consent, interviews, behavioral observation, facilitated focus groups, simple specimen collection and processing, and physical exams. The Research Programming Task Force also recommended incorporating an additional 10,000 square feet of research program-specific space into the PRAB, which was consistent with this vision of an integrated continuum of researchers throughout the 4 discovery themes. And the Space Committee, while endorsing this integrated research vision, asked the Tiger team to explore other possible solutions to program-specific space in Discovery Theme C. So Discovery Theme C was envisioned as spanning southern Parnassus Avenue buildings that are in the red oval on the right, recommended that 10,000 square feet of program-specific clinical research space be located in the clinical sciences building or medical sciences building, and that the space be prioritized for programs that are aligned with this Discovery Theme C. And connectivity between the PRAB and the program-specific clinical research space is really going to be essential to creating that continuum and community of investigators that will drive the innovation. Further, we recommend that the program-specific clinical research space should be organized into research neighborhoods that are administered locally. So the unit should include program-specific space for convening investigators' office work, storage of research materials, and be connected by common space or hubs to accommodate the shared needs and congregation. So it's critical that the program-specific clinical research space is organized and not simply located in space as it becomes available ad hoc, which will require campus-level collaboration and coordination across departments and schools. And that concludes the Tiger team's recommendations on this PRAB-based low-intensity clinical research unit and recommendations for accommodating the program-specific clinical research space aligned with Discovery Theme C. So I'm now going to turn it over to Susan Chang and Carol McGuire, who are going to do the high-intensity participant-based clinical research space.
Thank you very much, Pamela, for that. And I will present on behalf of our group looking at the high-intensity participant-based clinical research space. So this is our working group members. I'm very happy to present on their behalf. Our charge was to look at recommendations for where high-intensity participant-based clinical research would be located and what it should accommodate, as well as recommendations of how UCSF should approach assigning and developing future high-intensity participant-based clinical research. So first of all, just to define what high-intensity participant-based research is as compared to the low-intensity, we recognize that this consisted of two different areas. One, the hospital-based research involving inpatients. For example, patients who may be receiving living therapeutics. The other would be research involving ambulatory patients requiring the use of outpatient facilities for the conduct of clinical procedures such as infusion of agents, frequent and serial blood draws, or close clinical monitoring. I think some of the overview comments includes that the conduct of high-intensity participant research at UCSF adds significant value to the enterprise and is a core part of our academic mission, in addition to providing outstanding care and education. The main challenge is how to operationalize this in high-intensity participant-based research to be conducted in an academic clinical environment in an integrated and coordinated way. So the recommendations include that the space should be a part of and or proximate to current and future clinical facilities on the east side of the Parnassus campus. And a high-intensity participant-based clinical research space planning should be an integral part of any future UCSF academic medical center planning at Parnassus. The planning should, when possible, be programmatic and align with the discovery themes as proposed by the Parnassus Space Planning Task Force. And this should be integrated in what is envisioned for basic science research. So in terms of the high intensity inpatient research, the recommendations include the fact that there is tremendous opportunity at the UCSF Academic Medical Center, Parnassus, to demonstrate the value of integrating clinical care and research in the inpatient setting. And a great example of this is the Heme BMT and the Living Therapeutics initiatives, which are models for inpatient research that blends the delivery of standard of care with research. And these should be explored for other units. It's clear that inpatient research should be facilitated by clarifying the process of bed allocation for research, the training core staff to provide clinical care as well as research procedures, and integrating the research operations into the clinical environment. For the ambulatory participant-based research, outpatient high-intensity participant-based research space, like the current CTSI unit, should have extended capacity, for example, 7 days a week with extended hours per day, ensuring that there is sufficient personnel to support the activities. Similarly, the Moffitt-based hospital should have a dedicated space for high-intensity participant-based research, for example, for the Center for Innovative Medicine. And these disease, discipline, and organ-specific clinical research units can be a model in Moffitt West for ambulatory participant-based research. It's important that the space should be certified to complete the research procedures in combination with standard of care that is billable to insurance. So thank you very much on behalf of this Tiger team. And I'd like to now introduce Tom Chi.
Thank you so much. Thank you to the Academic Senate for holding this town hall, and for Hal and his leadership, and Dan for bringing us all together. So I'm presenting on behalf of the Tiger Team number 3 for non-participant-based clinical research space. And if you're wondering to yourself, what does non-participant-based clinical research space mean? That will bring us to our first set of questions. So I do want to acknowledge our team. It was a terrific team made up of Oisang Hong, Joanne Otani, and Rada Savic, representing different schools and different types of non-participant-based clinical research. And our working group was charged with recommending where this type of clinical research should be located, and what it should accommodate. And then also make some recommendations as far as how the UCSF entity should approach assigning and developing this type of space, so that non-participant-based clinical research space could really thrive and accommodate its community members. And we met several times over the course of the last several weeks in order to bring these recommendations in front of you. And the first thing that we kind of try to take stock of was, well, we imagine in our heads what this non-participant-based clinical research looks like, because I think many of us participated in many different levels, whether it's on the side or part of an R01 or R-level and a federally funded grant mandate. And for many of our realities, this is kind of what our space looks like. You're just trying to cram as much of stuff into any corner that you can, so patients will never see it. So it's not that embarrassing, but you can actually get the research done. And that might include binders with protocols and consents and test tubes and all sorts of things between your team members who are also crammed in these knee holes. So we took a stock of kind of where we're at, and hopefully these pictures kind of look familiar to you if you participate in this type of research. And the second thing that we did was to then try to understand how could we define what non-participant based clinical research is, because in our view of things, the other high intensity clinical research, other types of research programs seemed a little bit more obvious and maybe a little bit less heterogeneous as far as who constitutes that type of research and who's doing that type of research. And so for us to try to understand who exactly we're talking about before we could get to assigning space, we zoomed in on trying to survey our local areas, our personal teams, folks that we knew who were involved in this type of research, to try to get a gauge of what exactly we're talking about. Because I think that's the number one thing that we came to, which is having a good understanding of who exactly we're talking about, who would occupy these clinical research spaces. And some examples that we've had listed here for you would include clinical trials where patients are infrequently seen or touched. So, rather than the high intensity type research that was just described to you, where you have ongoing monitoring in an in-hospital setting, this might include the occasional visit to the clinic or an occasional visit to a research space. Clinical outcomes and retrospective cohort studies. So this type of clinical research that occurs in databases. Certainly computational research, any type of research that's specifically in epidemiology and biostats that has no patient-facing component to it. But also there's community-based clinical research. So research that happens out in the field and people are bringing their data back for analysis, but their actual contact with patients or others are out in the community. That type of research might also fall into this type of category. And then, of course, we have a big category of things like health services research and health policy research, of which there are many active research groups here at Parnassus and across the university. And what we came to realize was that while surveying our own local groups gave us a sense of what we think we're talking about, there probably is more out there. And so when we secondarily asked teams around us in our local areas what type of research they do and then what their needs are, we came across many different types of resources that were asked for. This included things like offices. Those are a mixture of private offices and shared offices and cubicles. The concept of learning our lessons from things like Mission Hall, where maybe the space was not set up to be shared very well. So noise control, noise pollution types of issues have to be accounted for. And of course, there are shared resources that many different research groups amongst different types of non-participant based clinical research also identified that were in common. Things like storage areas for study materials or equipment or documents. For folks who are engaged in high intensity computational research, making sure that we have infrastructure available for storage and care of electronics. So server rooms and temperature controlled spaces to make sure that we never overheated things and we had the proper electricity to be able to support those types of research infrastructure. And then of course, conference room space. We live in a very different era than we did 3 years ago now, where people do spend a fair amount of time off campus as compared to being on campus. But there's still a lot of value that was recognized to being able to have shared space for people to come together, to discuss issues, to bring a research team together. But perhaps we're talking about shared conference room spaces as opposed to specific spaces that are assigned to teams or groups. And we also did make the point that within that type of context of non-participant based clinical research, we do have great models that already exist, and we don't have to look very far. The furthest we could look was even maybe just Mission Bay. So courtesy of Rada Savic's lab, we took some pictures from her lab, and what you can see is some on the bottom right side, some very nice examples here of this type of non-participant based clinical research space where there's shared space, well organized, people can come together and have a shared community, be able to talk over ideas. And if you come even closer to home on the Parnassus campus, you also don't need to go very far. So some of the floors on the Health Sciences East Tower, for example, have been renovated already. So this is a nice example from the cardiology labs up on HSE 12, where you can see that the space has been renovated so it pushes out all the way to the windows. You've got some areas of shared cubicles and private offices where people have nice working space for non-participant based clinical research and can kind of bring ideas together at a table and have a functional place where people are proud of to come to work to do their research. Now, the next question that we had at hand was really, okay, if we could define who these teams are and who these people are and what their needs are, well, where would all of this space go to? And as you saw from the previous shares, there is this concept within the new renovation of the Parnassus space that we can place programs together in themes. Amongst non-participant based clinical research, we also recognize that perhaps this of all the groups is the one research group that's a little bit heterogeneous and perhaps doesn't need to be as closely integrated into clinical programs and patient-facing programs as much as perhaps the other groups would need to be. And so when we reached out then to try to get a survey of what type of space and where the space would be located, those answers became fairly obvious actually right away. And what we learned was that really the best spaces probably to put this type of research space in would be, for example, outdated lab space that currently exists. And the medical sciences building is a great example. So that's kind of, in this area right here. And that type of space is outdated, could be renovated or converted, as we saw with that HSE floor. Also, the upper floors of buildings that are unusable for basic science or benchtop laboratory space because of change in codes or chemical loading or safety issues, those are also obvious places to be able to put this type of research space into. And examples of those would be the upper floors of the Health Sciences East and Health Sciences West towers. And then the third category of space that kind of came right to the top of a place that could be easily kind of reimagined for this type of non-participant based clinical research space would be administrative space that's vacated, especially in the context of new remote work. And that example that came to the top right away was the Clinical Sciences Building, where we do see there's probably opportunity there to use space that's currently assigned, but then reassign it to folks engaged in this type of research in order to be able to utilize the space most fully. So our overall recommendations that came out of this particular Tiger team for non-participant based clinical research was really that, number one, we have to have a very formal effort to be undertaken to define who and what we're talking about when it comes to non-participant based clinical research at Parnassus, because it's a very heterogeneous group. And while we, during our last few weeks of going out and surveying folks and asking these questions, we have come up with a list of different types of research that we think encompasses this, but we're not sure if it's complete or full. And so I think it's really important. We feel that it's really important to have a formal accounting for who falls in this category and who needs to be accounted for. And so that would probably entail an assessment of the individual investigators at that level, also at the level of programs to figure out what programs are engaged in this type of research and who actually feels that they themselves fall into this category. And within those categories of research teams, who aligns with the 4 discovery themes, and so who may need to go into another space category to be closer to an integrated discovery theme program versus who could be put into different portions of the space identified that may be a little bit further away from those types of programmatic theme areas. The other question at hand is really, in this category, it being so heterogeneous, in the era of remote work and hybrid work, how much of that space really needs to be dedicated space and how much of it can be shared workspace, which would be acceptable. And then the final question that we thought was really important to come to as far as that formal survey effort is identification of the shared resources. So in that context, the conference rooms and the storage spaces and the infrastructure that's needed for shared things like computers and servers, how much of that is needed amongst all the different teams and amongst all the different programs and investigators, and how can that be allocated and managed. And the final thing that this Tiger team came towards as far as a recommendation is concerned is that we also recognize that within non-participant based clinical research, we probably do lag behind a lot of basic science programs when it comes to governance as far as clarity and transparency for space utilization. And so we think it's very important that particularly for this, this type of research that crosses over multiple programs, multiple departments, and multiple different disciplines, that there's real clarity as far as how frequently space is reviewed and very transparent criteria for reassignment of space if it's underutilized and what that actually looks like and means to people. So that transparency we feel is going to be really important for us. And I think that there are some good models within basic science, for example, that already have models for that type of transparency and governance. And so we don't need to look terribly far to find new models that could be applied to this type of clinical research space allocation as well. But we thought it's also very important that we involve faculty and staff in that overall governance structure. And so those were the recommendations that this Tiger team brought forward with response to the questions regarding non-participant based clinical research. So thank you for your time, and I'm going to turn it back to Sri.
Tom, thanks a lot. This is Hal. I'm just going to step in for a second and share one more slide by way of summary. Thank you very much to all of our working group presenters. We just wanted to show one by way of summary slide for you here. Hopefully you can see this, that just attempts to integrate the some of the recommendations from the 3 working groups. It doesn't cover all of them, particularly the process related ones, but just kind of by way of overview, showing how this work overlays on the physical revisioning of Parnassus. So as Pam presented, there is a recommendation for a low intensity participant based clinical research unit as a shared resource in the new PRAB building on the west end of campus. And then for discovery theme C program specific space to be organized into CRUs and connected somehow to the PRAB, perhaps in the clinical sciences building or medical sciences building as part of discovery theme C. Susan and Carol presented several recommendations, among them that high intensity inpatient-based research should be integrated into the clinical space. And I just want to comment that that is an ongoing conversation and has been very much a part of the planning process to date and will continue to be. And I think this effort will help the leadership of that effort, I know, who are really interested in achieving that. Also a recommended high intensity outpatient-based research space be organized into CRUs, maybe in Moffitt space that becomes available in the ACC building in clinical spaces, and that have extended hours of support to really mirror the clinical enterprise, which is 24/7. And then for non-participant based research, finding space that is both appropriate and or can be refurbished, and also fits in perhaps in areas where other types of research can't use it. So high floors or laboratory space that's out of date and can't be refurbished. And then underlying all of this is that the space planning should, whenever possible, align programmatically with the discovery themes, really trying to leverage in all of these recommendations the work of the previous 3 task forces. So hopefully those recommendations are useful to the Space Committee. I am really grateful for the work of the Tiger team and think they will be. This will be presented formally to the Space Committee next week, and there will be a report submitted as well, and then we'll look to continue to help as we can the Space Committee with its work going forward. So that ends the presentation of our report. We now are going to transition to a question and answer session with the full Tiger team, and I'm going to hand it over to Sri, who's going to moderate that.
Thank you, Hal, and all the members of the Tiger team, Pam, Susan, and Tom, for your presentations. It was really useful to hear all the work you've done and the presentation you're making. The floor is open for questions. I just wanted to invite the participants to submit their questions through the Q&A I guess, option on the instead of the chat. I know Legna has one question, which is actually something, let's use that to get teed off. I think the larger context actually for Legna's question is there a plan to organize and allow groups to book the research rooms for research visits? She's a CRC, so wondering how that would work. I think the broader question is how was there a discussion within the Tiger team of how these I guess this applies not just to the low touch research space, but generally to these clinical spaces wouldn't get allocated or assigned to specific investigators, and there should be a sort of a flexible system for usage. And I think this has come up is that this would be outside the CTSI involvement. So wondering if the panelists had any thoughts on how sort of what infrastructure would be appropriate and ideal for this. Sandy, go ahead, please.
I'll take a stab at this. Of course, anybody else. I think that there can be a hybrid type of approach. There can be general space that is reservation based, and that is the concept and the plan for the low intensity space that is happening within the PRAB building itself, the 8 or 10,000 feet, which is what Pam and her group spoke to. That is reservation-based space. I think many of us along the lines of a programmatic approach think that it's very important to have communities with synergies and efficiencies, and that there would be other space to see patients where it would be a hybrid, where high volume clinical research programs may be given some space that they could quote unquote control, because that helps the research program function in terms of accommodating more unpredictable visits. For example, Maria Dallara always talks about a flare where people need to come in and be seen with 1 day's notice, in which case competing for reservation space would potentially compromise that type of research. On the other hand, we don't want space just be held hostage by programs and not be utilized. So that's what I mean, a hybrid, some amount, hopefully modest, but significant to help programs, but also definitely wide open research-based space that would accommodate the campus, hopefully organized in a programmatic manner, again, to achieve synergies and efficiencies.
Thank you, Sandy. Hal?
Yes, Sri, I just wanted to add, I agree with Sandy's a great comment by Sandy, just to add about the shared space. One thing that's come up as a concern about shared resource like this is barrier to entry, that it could be, kind of to Sandy's point that, often you need space pretty quickly, and that's one of the reasons people like to have control of space, is that they can, be very flexible. We're really envisioning this shared resource as a low barrier to entry space that recognizes the need for, that things can't always be planned out weeks ahead of time. And to the point of, it may, for example, be space that you staff with your own research team. It's administered by, a central organization perhaps, but the CTSI or some similar, administrative group, but that the activities are carried out by your team, and that getting into the space is relatively straightforward. So just if there are listeners who, when they hear shared space, worry about flexibility, I think there is a solution to, getting the benefits of shared space, but also making it usable for that type of a situation. So I just wanted to add that comment.
Thank you, Hal. Just wanted to, Steve Hetz has chimed in whether this proposal for shared space could be scheduled like block time for OR cases or some other sort of lower barrier to entry. I also wanted to chime in if the panel had thought about a little bit about how, sometimes if shared space has to be assigned and there's sort of a charge for that, that might be a barrier for junior faculty, and whether that is something that has also come up. And then I'll get to you, Pam, sorry. Unless Pam, you
Well,
want to take that on.
Yeah,
Sorry.
actually, I'm always the one complaining about the charge. It did come up some from our faculty propensity research is that sometimes it doesn't cost a whole lot, right? Especially if you're staffing it yourself. And some folks, sorry, my internet connection is unstable. Some folks really felt like having it be very low cost, particularly if you're not asking for specialized procedures, would be important, particularly for junior faculty and low intensity things like focus groups or interviews.
Thank you. Did you have any other thing comment to add, Pam? Yeah, I think that, thank you. One of the other questions that came up was about, in the low touch research, there was a lot about its being potentially in the PRAB or the C building and alignment to discovery theme C. And we didn't hear, although I think, Hal, you made the broader point that in general, all sort of clinical research, either high touch or dry research, we want them generally to be aligned to the discovery themes. But do you guys, maybe the panel had talked a little bit about how to sort of maintain this, as well as maintain some flexibility, because there might be, if we talk about either PI assignment, especially in the low touch units, there's been talks about PIs with clinical research under the discovery theme would get assigned, and how that would have to be sort of balanced with this idea that we've just been talking about shared space and more sort of use it as you need it kind of basis. Was there sort of thought about how that could be implemented, or some barriers on that? Yeah.
Sri, I can take a stab at that. I don't know if I am exactly addressing your question, but what I heard in it was that, how do we kind of reconcile the different desires here? One is for the discovery theme distribution. One is this, clinical gradient. One is shared space versus investigator specific space, and who gets priority for certain types of locations. I think I don't think we have a solution to that yet, but I would say I kind of think of these all as principles, by which we look to make decisions about space as both as a general approach, but also in the moment when there's space decisions to be made. I'll say, this Tiger team really wasn't charged with developing kind of governance or process around space. That is the job of the campus space committee. So Dan or others may be able to comment on that, but I think it's the operation of this is critical. I think that's a future step, and we'll need to look to the space committee for leadership on that, which I know that's the type of thing that they think carefully about. I don't know if that's exactly what you were asking, Sri, but that's what I heard in it. And it certainly was something that we talked a lot about.
I think that's good paraphrasing. I like this notion that there are sort of three principles and governing principles that we would like to have in the implementation, which is alignment to discovery themes, and to the extent possible, have this sort of hybrid of shared with assignment that makes things efficient rather than barriers, and then this sort of gradient, I think, like you've already talked about. So those seem like good principles to sort of think about as we conceptualize implementation of this. There are a couple of other questions about. One is about, in general, it looks like space designated in the PRAB building will be limited to non-participants-based clinical research. I think that seems to be the echoing based on this gradient approach. Do you envision, I guess I'm going to paraphrase a little bit based on the question here. Do you envision some needs for some sort of maybe not some gradients, maybe not high touch, but sort of medium touch research that would be impacted along the western end of the campus in Parnassus? Carol, go ahead.
Yeah, I mean, I don't want to speak up for that Tiger Team working group, but I think that what is envisioned is that space would be used for really low touch kind of behavioral based research, you know, a space where you can do simple consenting, simple phlebotomy, and have some storage space. So there would be some patient facing research there, but it would be very low intensity.
Thank you. Pam?
Yeah, I agree with Carol.
Great.
Speaking up for that team,
Right.
yeah, I think.
Okay. There's one more question that's come up, which is what are the Tiger Team's thoughts on the timeline for assigning clinical research space? It's that I think no, I think it says note that the new construction is several years away, but that other locations might be available more. So is that up to the space committee's discretion, or what are the Tigers team's thoughts on timelines? Maybe that's generally the summary of that question.
Sri, I can comment. I think that was outside of the scope of the Tiger Team, and we didn't really form an opinion on that. I mean, I do think that the decisions on this are coming in relative quite soon, particularly with regards to new construction. And so I know that's something that I think the Space Committee will be commenting on soon. But yeah, that one of the reasons this was a Tiger Team was that we knew we needed to get this these recommendations in quickly to the Space Committee so that they could use them to make decisions. So I know that they're actively working on this, but I don't know how that translates into an actual kind of calendar timeline.
Great, thank you. The last question that came up at the Academic Senate after Hal's presentation was whether the Tiger Team had thought a little bit about how this might impact recruitment of clinical faculty and clinical research faculty, and what, if any, we should be thinking about as we're sort of high-level designing of clinical space at Parnassus in the context of recruitment. Any thoughts on that from the panel? Go ahead, Tom.
I mean, I can certainly offer my my thoughts just as a Tiger Team member. I mean, the drive behind the work for the Tiger Team was, get out there, try to figure this out fast and make this a reality, or at least, provide some input from the community on how to bring this closer towards reality. And I think that's exciting. So, to me, it shows a commitment that everybody really wants to see this as a reality, to really kind of re-envision what that future for research space looks like here. And to me, that should already be a selling point for us recruiting and retaining faculty right now and in today's point in time, because I don't think there's anybody here who's thinking their SEDS, this is all going to disappear in like a year, like all this many years of effort is just going to fade away into nothing. I think this is going to be a focal point for where we're going.
Thank you, Tom. Susan?
Yeah, I just wanted to say that I think as an academic institution that really values research, I think it does, this sort of effort is really key for people who are looking to do outstanding clinical research, both the high intensity and especially with a lot of novel therapeutics, a lot of intense PK/PD, sort of very, very early phase types of trials. This is the kind of environment that they're going to be looking for as we plan a new hospital. And so I think that this is really critical to integrate into the planning so that we can attract the sort of really high-end academic researchers who are interested in translating the basic discoveries that we do all the time to our patients. So I do think that this would be a major, major draw.
Thank you, Susan. Carol?
Yeah, so I know for the Division of Cardiology that our research infrastructure is a huge drawing point for new faculty members. I'd say that one of the biggest barriers that we're having is we've been bringing in these really great faculty members, and they're bringing phase 1 and phase 2 clinical trials, that we don't have this infrastructure to be able to support that. And so it's almost a little, you know, we bring them in and we promise them we do have a great infrastructure, but we don't have the facilities to do these more high intensity clinical trials, which has, you know, been frustrating.
Thank you. There's a couple of other questions that I also have come up, which is one is about.
Sri, I think Pam's hand is up. I don't know
Oh,
if you can
sorry.
see
Go
it.
ahead,
But yeah.
Pam. Yeah. Go ahead.
That's okay. I just wanted to bring the perspective more from the low intensity and the non-clinical research, that I think just having access to thoughtfully space rather than and whatever you hold of is have like only a space. If you had access to high quality space, those interactions and for that other research.
Sorry,
I
Pam,
think it's
your internet was unstable, so we were only hearing a little bit of what you could say. Maybe if you could type it in, that would be helpful. Let's go to Susan.
I just wanted to say, when we think about recruitment and retention, we're not only speaking about faculty, but it's all the research personnel that are involved in what we do. And having a sense of community and an organized, synergistic approach that's efficient is really something that I think all of our research personnel are really crave. They would love to have the ability to learn from each other. And so having an organized environment for them that is very supportive is going to be also critical to attract and retain the great talent we have here and who work so hard with us to get the work done in terms of the research.
Thanks, Susan. Yeah, I would just add to that, I'll get to you, Hal, I think the question was also about, in addition to faculty, staff, I think you already brought that up, and that was one of the questions we had. And the other was patients and convenience for patients. So we have to, I don't know whether the team had conceptualized thinking about convenience, parking, and also maybe childcare access for patients and staff while research is going on. These are some things that a couple of people had talked about. Let's go to you, Hal, and then to Sandy.
Yeah, Sri, thank you. First of all, this is the question of the hour. I mean, look at the interest. It's such a important question. And I just want to highlight one thing I've heard from a number of faculty that I think is addition to what's been said, which is this concept of the CRUs that was mentioned by a couple of the groups. I think for recruiting a lot of high-level clinical research faculty, that concept is critical, and the governance of that space is critical too. So I think this gets back to the previous discussion about we need to work out a balance, that is efficient and has a coordinated institutional vision, but also gives enough control and resources to individual investigators, to be able to conduct their research efficiently and kind of follow the clinical science. So I think that that's going to be a critical component of how do we take that concept and realize it, both for high and low intensity research.
Thank you, Hal. Sandy?
Yeah, I think the only other dimension that I might want to just bring out is, I think over the last 2 to 3 decades, this label of clinical research has really grown in the dimensions and the expertise. 20, 30 years ago, we thought mostly about people doing, database outcomes. There's participant-based research. The things that were done in the CRC that required overnight stays were metabolic testing and PKs and PDs. There wasn't maybe the same dimension of risk that we're mentioning now with CAR T cells and other cellular therapies, which are, first of all, incredibly complex at the manufacturing end, and the lack of infrastructure and flexibility at the patient-facing end really makes this type of research very, very difficult to conduct because it's got so many dimensions of complexity. And so I think that this idea that we have a gradient of risk from west low to high east, that we have communities rather than departments and divisions where expertise can be shared is really our vision for Parnassus, and it should extend and guide the planning for the programs and the space that we're now discussing, which I think is the way the basic science community is shifting. It's not quite as department or division focused, but more programmatically based. So I think the complexity and the breadth of the research that we're doing, along with the depth, makes this new planning approach really essential.
Thank you, Sandy. Joanne, let's go to you for the last comment, and then we can close out.
Great, thank you. Thank you so much. Going back to what Shri had mentioned about patients and this gradient from west to east, I think it's important to also, I work in oncology, and I think one thing that I've seen in patients over time is that they prefer if they feel that they're cured, if they're in the survivorship aspects, the last thing they want to do is return to a hospital or clinic location. So I really think the importance of the PRAB and the space in a community type setting where it's not a sterile clinic environment is something that would really be special for them to help participate in survivorship and other community-based research. That's important.
Thank you. That's an excellent point, and really expands the notion of low touch research in terms of thinking about who would be participating in that kind of research. It's a very good point. Thank you. With that, I think we're at the hour, and I don't think there are any open questions in Q&A. So I would like to thank Hal and the Tiger team for your excellent presentation, for your recommendations, and I look forward to hearing more through the various channels. Is there a way people, if they want to contact the Tiger team, that they could reach out to you for comments? Hal?
Yes, Sri, I'd say two things. One, this town hall is recorded and will be posted on the Office of Research website. And I think they can reach out through the Office of Research. It's research@ucsf.edu. That's probably the best way to reach us.
Great. With that, thank you all for coming, and look forward to seeing you all. Bye.